प्रॉब्लम हो रही है?
नो सर, नो इश्यू।
अच्छा, वो वहां तक पहुंच गया। ये है ऑटो एकॉस्टिक एमिशन। लेकिन मैंने क्या बताया, सूरत के बाद ट्रेन जो है इलेक्ट्रिकल इंजन में बदल गया। तो ऑटो एकॉस्टिक एमिशन, जो साउंड गया था वो कॉक्लिया तक जाके वापस आया इको की तरह, और हमने उसको पकड़ लिया, उसको हम कहते हैं ऑटो एकॉस्टिक एमिशन। लेकिन जो साउंड अब कॉक्लिया के आगे जाएगा, यानी सूरत के आगे जाएगा, वो चला गया बरूच में। जब बरूच पहुंच गया तो हमने कहा ब्रेन स्टेम पे पहुंच गया। तो जो बरूच है वो होता है ब्रेन स्टेम। अब ये इलेक्ट्रिकल सिग्नल है, तो हमें स्कल के ऊपर कोई ऐसा इंस्ट्रूमेंट लगाना पड़ेगा जो ये इलेक्ट्रिकल सिग्नल पकड़ ले। उसको हम लोग बोलते हैं बेरा, ब्रेन स्टेम ऑडिटरी इवोक्ड रिस्पॉन्स, या BER, ब्रेन स्टेम ऑडिटरी इवोक्ड रिस्पॉन्स। What response? The sound wave which traveled from Mumbai or outer ear and via Valsad, which was the eardrum, reached Surat, now has reached Bharuch, and now it is an electrical signal which has been picked up. Beyond Bharuch, Vadodara is the brain. So from the brainstem to the brain, there is still a pathway. That pathway can only understand if you have listened to me, your brain has been able to understand, and you respond back. That can be done through behavior audiometry. So whenever you are training this, how will you train? So among the participants, ask someone to be the Mumbai. So one of you just raise your hands and you are the Mumbai. You don't have to speak, just raise your hand. Any one person volunteer?
Okay.
So you are the Mumbai. Remember your name.
Yes.
Then the next person is Valsad.
Who will be Valsad?
Yeah. No, don't raise too many. Only one person.
Only one person, yes.
So
Should I
Valsad.
speak the names?
Yeah. So
Yes.
also remember your name to be Valsad or eardrum. The person.
Valsad.
Yeah. So the person who was Mumbai was the outer ear. The person who is Valsad should also, outer ear, the Valsad should know his name also as eardrum. Then please volunteer for the third person, Surat. Anyone. Just remember your name.
Yes, Dr.
Surat.
Surat.
So you are, Surat is cochlea. And then Bharuch. Anyone volunteer for Bharuch?
Okay.
So Bharuch is the brain stem. And finally Vadodara is the brain. So the last volunteer should be the Vadodara. So now, madam, can you tell me?
Yes.
Who is Mumbai? What's his name?
Dr. Bhautik Modi.
Okay. So you have another name also apart from Vadodara. You also are the outer ear.
Okay.
Who is? So who is the Valsad? Who was the doctor for Valsad?
Dr. Neetal.
Okay,
Dr. Neetal.
So what is your another name?
Eardrum.
Eardrum. So then you have Surat. Yes.
Dr. Suman, cochlear layer.
You are the also the Surat is also another
Cochlear
name.
layer.
Cochlear. Good. And Bharuch. Yes, you are the brainstem. So
Dr. Jayesh, brainstem.
Okay. Sir, so no, just hold on your mic. Hold on to your mic. Hold on. Yes. So which instrument can I test that the railway pathway from Bombay to your place is okay? Which instrument?
OE.
No, not OE. You are
Bera.
Bera. Because Bera is an electrical signal. From Surat to Bharuch, the train has changed. It is now
Surat to
electrical
Bharuch.
signal. So you were Bharuch, isn't it? Yes, sir? Hello? Yeah. Now, who was Surat?
Dr. Suman.
Dr. Suman, if I have to test the pathway, which instrument will I use?
OE.
OA, very good. So remember, OA only sees up to the cochlea. Beyond cochlea, that is beyond Surat up to Bharuch, you can only test through Bera. Now beyond Bera or beyond Bharuch till Valsad, how can I test?
Till Vadodara. No?
Yeah, till Vadodara. How can we test?
Behavioral audiometry.
Very good. So I think all of you have understood. See, for you, this was not required. But when you are teaching your students, you are training nursing staffs, you have to give it a simplified way so that they understand that what is this. Sometimes even doctors also think that by doing Bera, I have screened for deafness. Or by doing OA, I have screened for deafness. So the retrocochlear pathway can only be tested in Bera. So now tell me, if there is a child who has been admitted to your sick newborn care unit, whom you have treated with antibiotics, including aminoglycoside, which instrument will you use for screening?
OA.
OA. So most of the damage in your NICU because of aminoglycosides, because of jaundice, is in the neural pathway, that is beyond the cochlea. So now tell me, which instrument will you use?
Responses are Bera, sir.
Bera, very good. So remember that if I have a child who was admitted to SNCU for the first screening, I will use Bera. But if a child was not admitted to SNCU, then I will use OA. And later on, when the child has passed his newborn period in the follow-up, I will not say just because he has passed his OA or Bera that you are okay. I will say up till now I have not been able to detect a problem. I would require a behavioral audiometry because the train has not reached Vadodara. It has only reached Bharuch and there is still a pathway to be covered. So behavioral audiometry. So have you all understood how the deafness screening has to be done? So let me repeat. If you have to just test the outer ear, then I can use a simple torch. What kind of defects can I capture? Whether the ear is formed normally or not. So if a ear is not formed normally, A means absent, otia in Latin means ear, so absence of ear, anotia. Or microtia, that means micro means small, tia is again for ear, the ear is small. So if you find a deformed ear, the chances of deafness is very high. So first, through simple torch, you can see whether there is a anotia or there is a microtia or there is some preauricular sinus. This can be seen as a structural defect. If you want to see the Mumbai railway station, Then you use a simple instrument which will allow you to see up to the eardrum. What is that instrument? Otoscope or a scope. So by that you can see up to the eardrum. If you have to see from the eardrum, that is from the Valsara to Surat, that is from the eardrum to the cochlea, the middle ear, then how will I see? I will use impedance audiometry. And I will see that the eustachian tube is open up. So I can use impedance audiometry. That means the sound which was going, instead of getting amplified, is impeded, is obstructed. So I can see. Once it has reached cochlea, then I can use OAE. Once it is beyond cochlea, then I will use BERA, because now it is electrical engine, the electrical signal. And once it has reached up to the brainstem, from the brainstem to the brain, we will require behavioral audiometry to be very sure. So this is, in short, how to screen for deafness, in which population what to use. Supposing I have a population, 50% of the congenital deafness are run in families. So by taking a history of the parents, you should be able to screen whether you are at low risk or high risk. I would advise that in high risk, you do BERA. In low risk, you do OAE. Similarly, for vision, how am I going to screen for vision? So for vision, I will use, I said vision is a game of 3 circles. So I would be happy if all of you draw 3 circles. So the innermost circle, write it black. Then the next circle, so I again repeat, the innermost circle is black. The next circle is brown. And the third circle, which is the largest circle, is white. So the largest circle is white. Then you have another circle which is brown. And then you have the innermost circle which is black. Now the circle which is black in Latin is also known as the pupil. No, sorry. Yeah, you can say the pupil. And the circle which is brown, that is your iris. Some people have brown, some people will be having, you can say blue also, depends upon what genetical group do you belong to. And the third circle is white, is the sclera. So white is the sclera, the brown is the iris, and the black is the pupil. Now, or we can also say the lens. Now, if the black is white, instead of the black, you are using a torch. Instead of the black circle is white. Then what it is? It is cataract. Okay. Yeah, after 1 hour. Achha, you have to also get a tea break, isn't it? Please inform me. I'll just complete this slide and you can take a tea break if you want. Or whenever you wish. So, for the, if the blackmost circle is white, then we call cataract. Now, cataract is a Latin word. आप हिंदी में क्या बोलते हैं उसको? मोतियाबिंद. Just see how good a term is. The innermost circle is like a pearl and it is got a white color. So if it is pearly white color, you can diagnose it as cataract. Then the next circle is brown. Now instead of this brown, it has got multiple colors, as if someone has thrown some paint inside it. This is known as hetero. Hetero means different, multiple. Heterochromia. Chromia means light. Heterochromia. So heterochromia is a thing which is seen in Down syndrome and in Southern. So instead of one color, you have multiple colors. That is heterochromia. Now instead of it being round, the second circle, instead of being round, there is a cut in it, like a keyhole. So just draw a key-like thing. So it is round, but there is a cut. If there is a cut, in Latin, cut is known also as coloboma. So we call it coloboma of the iris. So all I need to make you understand, is there a cut there or not? Is the iris of one color or not? Then the third circle is, of course, white. If instead of white, which is sclera, it is blue, then you can think of either normal or sometimes osteogenesis imperfecta, or sometimes in slightly older children, if there is a grayish triangular raised surface, then you can also think of vitamin A deficiency. And if the black circle and the brown circle both are white, and there is tearing of the eyes, that is congenital glaucoma. And if this both are white, but there is no tearing, then it is corneal opacity. So, how many things you have diagnosed? In the game of three circles, you have diagnosed congenital cataract, you have diagnosed heterochromia iris, you have diagnosed coloboma, you have diagnosed congenital glaucoma, you have diagnosed corneal clouding, and you have also diagnosed in the white sclera if there is osteogenesis imperfecta or there is vitamin A deficiency, not in newborns, in older children. Sometimes you will find a fleshy mass approaching the white circle from the limbus. Now this is a part of dermoid and it is golden hair syndrome. So I did not teach golden hair syndrome. I can just show them a photograph if this is there. Then come to the eyelid. If the eyelid is always closed, then it is ptosis. If the eyelid is missing, cut is there. As I told you, all cut is coloboma. It is coloboma of the eyelid. If the eyebrows are not there, then you know that there could be some ectodermal defect. If the eye is small, then we call microphthalmus. Micro means small, ophthalmos means eye, small eye. That means the entire eye is small. If there is no eye, then we call it anophthalmos. A means absence, absence of eye, anophthalmos. So anophthalmos, microphthalmos, ptosis of the eyelid, coloboma of the eyelid, absence of the eyebrows, and if there is some pigmentation close to the eye, like port wine stain, etc., then you know both the brain and the skin, there is a neuroectodermal origin. So there are some defects where the defect will be also in the brain as well as in the skin close to the vision. So for diagnosing all this, you require. Can't you teach this to your nursing staff? That every child born, at least take a torch and rule out that there is a cataract or not, his eyelid is properly there or not. And if you are still more intelligent, then I can show you through a simple camera if both your eyes are focusing at the same point or not. If the camera image is not falling in the center of the eye, then I can tell that you have a squint. So I can also catch hold of squint through this. So I always say that if you want to know in a particular area what are the defects of eye, don't go to the eye doctor. Go to the studio and go and look at the pictures pre-processed. Don't see post-processed. You can pick up a lot of eye defects by going to the studio and looking at the pictures. Then comes the congenital heart disease, where you use a stethoscope, you listen to the heart sounds, but you also use a pulse oximetry. Nowadays, due to corona, a lot of people are using pulse oximetry. The same pulse oximetry can be also used in newborn. So you use the right hand, which is preductal, and the left leg, which is postductal. So you see the saturation in both. If the saturation is less than 95, then repeat it. If it is still there, it is pathological. Or there is a difference of more than 3% between the upper limb and the lower limb. So all this is very, very important to screen. And then you can screen by taking a drop of blood for hemoglobinopathies. People thought that sickle cell only exists in tribal population. Let me tell you, it is more in tribal population, but even in the not tribal population, sickle cell is there. And if you have some more money, screen for congenital hypothyroidism, because every week you miss in diagnosing hypothyroidism, you actually lose 10 IQ points every week. So when you see a creatine and you are very happy that I have diagnosed congenital hypothyroidism, actually you have delayed the screening to a large extent. What about neurodevelopmental? So this is a complication of prematurity and birth asphyxia, and this can be identified. For those who are interested in public health, Vadodara can tell you how to bring down prematurity and how to bring down birth asphyxia. My simple request is please follow this in your own family. So the first line is, when you say a term child that is beyond 37 weeks, it is not a term. This is a misnomer. We were all taught that beyond 37 weeks is term. That is a misnomer. Why do I say misnomer? Because it actually means that your lungs have matured, you don't require an SMCU. It doesn't tell about your brain maturity. So between 37 to 39 weeks, the brain very rapidly matures. So please understand that the golden message is allow all mothers to complete at least 39 weeks before terminating it for non-medical reason. Because extrauterine, the brain development will never be the same as intrauterine. Very simple message. Just tell every pregnancy should continue at least up to 39 weeks. So you will ask Dr. Singh, how did you say this? So when people studied all newborns who were born between 37 to 39 weeks and those between 39 to 41 weeks, it was found that between 37 to 39 weeks had more neurodevelopmental problems. So don't become a god yourself. That is why most labor pains will start beyond 39 weeks. Second thing is birth asphyxia. Vadodara is doing a wonderful job. Government Medical College Vadodara doesn't cut the umbilical cord, it allows the blood to go. So supposing a child does not cry, that means his brain is not getting oxygen because his lungs have not opened up. his pulmonary circulation has not opened up. So please resuscitate the child, keeping the cord intact. The little amount of oxygen which was coming through the placenta was to protect the brain. By cutting that cord, you are denying the baby the oxygen. So nature was not a fool. It was for a purpose that it had placenta. It was for a purpose that it had such a long umbilical cord. And nature wanted that in the mother's womb, oxygen was coming through the placenta. After birth, it will come through air, through lungs. So there requires a time. Till it is established, you need to continue getting oxygen from the placenta. So all of you have understood. For those high-risk babies, those who are born preterm, those who are history of birth asphyxia, history of exchange, transfusion, they would require a more developmental assessment also for developmental delay. So what is the birth defects? Physical malformation, neural tube defect, cleft lip palate, limb deformity, club foot, all of them can be screened through your own eyes. Functional defect, your own eyes plus one instrument. Congenital deafness, congenital cataract, congenital glaucoma, or congenital heart disease. Metabolic disorder, you require a drop of blood. Congenital hypothyroidism, congenital adrenal hyperplasia, sickle cell disease. Chromosomal abnormality, again, you can screen only with eyes. It can be confirmed through karyotyping or other genetic testing. And neurodevelopment defect only in those who are admitted into your SNCU, were born premature, they are required to be screened for either birth asphyxia related neuromotor impairment or ROP. So you now know who will screen the visible. All visible defects should be screened at the delivery point. So next to your delivery, prepare a room, give simple things, a bell, a torch, and a poster. You will be able to screen the majority. If you still have some money, buy an OAE, buy a ophthalmoscope, and buy a pulse oximetry. You can screen for deafness, vision, and congenital heart disease. Metabolic, still more money, take a drop of blood and can screen. And chromosomal, it is mainly clinical. You may require a genetic lab support. And neuromotor is a skill set which you all have to learn how to examine the newborn before discharge neurologically. Out of every birth defect, 6 to 7 have a birth defect. But when you screen visible birth defect, you will get only 2 to 3, which is acceptable. So with a birth cohort of 2.6 crore, 17 lakh babies in our country are born and account for 9.6% of the newborn deaths. The major defects are only 5: congenital heart disease, neural tube defect, Down syndrome, hemoglobinopathies, and G6PD. 70% of birth defects are preventable. So, under RBSK, you are going to identify it. So, if you only screen in the first week, you will miss 40%. If you do 2 screening, one at birth and one at first month, you will be close to 70%. But if you screen up to 6 years repeatedly, you will come up to 96-97%. That is why under RBSK, we have multiple screening slots. So these are the different books which you will have to undertake and find your answers there. So for the delivery point doctors and nurses, there's a visible birth defect. There's also a book on functional birth to 6 weeks ASHA and 6 weeks to 6 years for the RBSK mobile health team consisting of Ayush doctor, male, female, a nurse, and a pharmacist. So, identification, recording and reporting, initial management, and counseling. So, examination will be performed by the staff nurse, ANM. You may require an extra nurse designated as newborn nurse. Every newborn nurse requires a brief examination within the first few months to see the respiration, heart rate, etc. But you also have to know the birth defect, head to toe, and then back to front. So when and where? At birth, at all delivery points. Who will do it? Existing A&M staff and doctors. What help will you want? A simple torch, maybe a bell, and a pictorial tool. So this is a simple thing. So after this, we'll break for tea. I think it is quite late. Do you want to break for tea, ma'am, right now or later?
Yeah, it's okay, sir.
No, you tell me, whatever time suits you.
4:15.
Sir, 4:15.
Okay. So when I always say, keep this posture and train. So when you see, I must look at the child, must take his weight, length, head circumference, must know his gestation, must see his movement, must see his tone. All newborns have flexed tone. That means both their hands and both their legs are flexed, especially in term children. In preterm children, you will get legs extended and hands extended. Actually, in the intrauterine limb, the legs flex first, then the trunk flexes, and then the hands flex, and then the neck flexes. So it is from bottom up. The legs will flex first, then the thighs, then the trunk, then the elbows, then the head. This is complete flexion tone. Now, if the child is born preterm, then it can be all is extended, or the legs are flexed and the hands are extended, but it can never be that hands are flexed and legs are extended. Again, I repeat that the cycle is पाँव पहले फ्लेक्स होगा, इसके बाद थाइस होगा, उसके बाद ट्रंक होगा, उसके बाद हाथ होगा, उसके बाद गर्दन होगी. लेकिन ऐसा नहीं हो सकता कि हाथ तो फ्लेक्स हैं और पाँव सीधा है. अगर ऐसा है, then it is always pathological. Then you need to do an MRI of the brain and see for some pathology. So what do you see in the abdomen? There is any abdominal distension due to any organ, in the hips, in the lower limbs for talipus, the back, midline defect, the genitalia, the femoral pulse, in the chest, the respiration, the heart sounds, heart murmur, the head and the face, the fontanelle, the face appearance, eye, mouth. So this is a simple thing which will help you. So after a baby is born, you see whether he is alive or not. Then you examine him for head to toe. If there is a birth defect, then you need to fill a form. So out of every 100 newborns, you'll find only 2 to 3. So you have to fill forms only among 100 for 2 to 3. And then you have to refer. So the state must make a directory with services available where. So if I am in Baruch, where do I send my child? Or if he suffers from congenital heart disease, if he suffers from neural tube defect, where do I send? Who is going to pay for the transport? All this needs to be prepared like a directory, and you should have complete information before sending a child. यहाँ नहीं होता है, बाहर जाओ, ऐसा नहीं बोलना है. You have to solve it. So examine head to toe, enlist the examination. If the examination is normal, well and good. If you find an abnormal defect, you try to find out how many are abnormal. Do you want confirmation test? So you can send him to the DIC where he can be confirmed, or if there's special investigations required, can be spent higher. So before you examine the newborn, you must remember that you must see the heart rate. So the heart rate when the child is awake, it is between 100 to 180. Why this? Because the heart rate, respiration, if they are not normal and you are trying to see the child for birth defect, you actually may lose the child. So whenever you have to touch the child, ask yourself, have you opened all the ornaments of your hand and fingers? Have you cleaned your hands properly? If you have cleaned it, then is the child awake? Is the child sleeping? And then whether the child is stable or not. Once the child is unstable, first try to stabilize. You can't say I was searching for birth defects and the child became unstable and died. So you should know what is the heart rate of a normal child. So when he is awake, it can go up to 180. When he is sleeping, it can go up to 160 from 80. The respiratory rate, it is 30 to 60 breaths per minute. The NIBP you can take. It may be difficult, but at least the systolic blood pressure is 80 in tertial. Tachycardia, if more than 160. Tachypnea, if there is a rapid breathing, which is more than 60. Hypotension defined if the blood pressure is less than 60. And then you can take the temperature, which is 36.5 to 37.5. So if it is less, then it is less. So this is how the head to toe examination will come. First, you have to see the cranium and the fontanelles. So start using your hand. First, look at the fontanelles. Move your hand on the skull. Is there any cranial swelling? What about the posterior fontanelle? The posterior fontanelle is usually closed by 2 months. Anterior closes by 18 months. Eyes. Is there a history of vision problems since childhood? Then the external examination of the eye, epicanthic fold, any eyelid problem, any facial marks, any absence of small eye, any visible abnormality in sclera, cornea, pupil, and red reflex. I will tell you what is red reflex. Red reflex is a very simple. All of you are sitting in a lecture theater and there is a door. If I look from outside the door and look inside, and that within the door there is a glass, which is the viewing glass. So if I put my eyes to the viewing glass and look at it, and all of you are sitting, then I will be able to see the curtain of that hall. That means the last wall behind you, that color I can see first. So, but if you stand up, then I cannot see. So when all of you are sitting, none of you are stopping my light, my vision, then I can see the color of the curtain or the color of the wall, which is behind all of you. Similarly, when you look through the eye, through the cornea, which is the glass viewing door, and you can see the retinal curtain, which is red in color, then it is known as red reflex. If there is some obstruction, then we say the red reflex is absent. That obstruction can be because of corneal clouding, that can be because of cataract, that can be because of vitreous hemorrhage, wherever it is, that can. What about ear? Family history ear, the shape and placement of ear. Philtrum, any cleft lip or abnormality. What is the philtrum? So you can see on your upper lip, if you track just near your mustaches, you find that the two upper lip, there's a depression. That depression tells you it has been joined here. So that is known as the philtrum. Then you see the inside lip and palate, chin and neck, the facial appearance, the general description. You look at the spine and the sternum, any breastfeeding, swelling, chest, respiratory rate, chest retractions, abdomen distension, mass, genitalia, then the penis, is there a hyperspadias, is there undescended testes or ambiguous, position and patency of anus. You must put your hands on the femoral pulses, the upper limb, look for extra digits and single transverse trace. On the lower, it is female. If you have to look at the hip, so which are the cases where there is more predilection of having hip dysplasia? So you'll have more hip dysplasia if it is female, if it is breech, or there's a family history of hip dysplasias. Also, the way you treat your newborns. If you keep both the legs together and tie it with a piece of cloth like a mummification, then the chance of congenital dislocation of hip increases. You will tell me why? Because the hip joint is a ball and socket joint. When you stand straight, a part of your ball is within the socket and a part is outside. But when you abduct your legs, then the ball moves into the socket. Now remember that the socket is also to increase in size and the ball also has to increase in size. So never keep the legs straight of a newborn and tie it with a cloth. This was being done in Japan, and they found that the congenital dislocation of hip, or the known as the developmental dysplasia of hip, they have increased. In the foot, check for clubfoot, any kind of a skin manifestation in terms of hypo or hyperpigmentation, including jaundice and cyanosis, must be seen. Always remember to check for the vital rate, that is HRT, heart rate, respiration, temperature. Now in the entire book, so I will ask all of you to download that book and the poster. Madam, please share with them. It can be downloaded. So please give them on the pen drive. Yeah. Now in the birth defect, you have urgent, you have semi-urgent and routine. Why is this important? Now a child came to you, you found a birth defect, and let's say the birth defect was a cleft lip. You referred him to Gandhinagar. When he went to the Gandhinagar hospital, the doctor there said, "Oh, what was the emergency? You could have come after 1 month." So what opinion does he get from the doctor? Or the doctor just simply harassed me. So in the referral form, you have to qualify whether it is urgent, whether it is semi-urgent, whether it is a routine referral. So the first thing in screening is always ask for risk factors. If somebody's parent is already deaf, then whatever is your answer of OE and BERA, don't tell him he's not deaf. Tell him you need to follow it. Up till now, the BERA and OE are normal. So assess the risk factors. If the risk factors are there and they consent to get it screened, screen within 72 hours. If there is a risk factor and your screening is negative, still call them once more. Repeat the screening at 6 to 8 weeks. And you can, so the whole idea is that if you are screening and your screen is negative, but there is a risk factor like a family history of deafness, family history of blindness, then you need to tell the parents you require multiple screening. One screening will not do. This is the poster. So you can show this poster, and you can see the poster has been designed in such a way that it is head to spine, eyes, ears, mouth and lips, abdomen and anus, genitalia, urinary tract, limbs and chromosomal disorder. If the nursing staff doesn't understand anything, but she thinks there's some abnormality, then you can supply this form and all she has to do is create a circle on this children. If you create a circle, then I know that there is a defect here. You do not know what defect is there. That you can do. There is an atlas with ICD-10 codes. So can I show them the atlas first? I think what I do, or anyway, let me go through the atlas. So as I told you, when you are teaching the nurses, go very quickly to the atlas and teach them each slide. So hydrocephalus. Now I would like all of you to understand the meaning of certain Latin words. Otherwise it is very, very confusing. So hydro means water, cephalus means head. When there is a large head, how do you understand there is a large head? You take a tape, take it around the circle. It should be placed just above your eyebrows, then just above your ears, and the most prominent part of your back of this skull, and measure it. That becomes your head circumference. If the head circumference is very small, let's say less than 32 centimeter in a term child, then you call it microcephaly. Micro-ophthalmos. Ophthalmos means eyes. Cephalus means head. Microcephaly. This is small head. Hydrocephalus. That means there is water in the head. Cephalus means head. So there is a dilatation of the ventricular system with or without enlargement of the skull. Anencephaly. Now these are neural tube defects. Why there is a neural tube defect? Now in the newborn, when the newborn was in the mother's womb, the brain was like a piece of white and it was flat. Then it started curving. This is formation of the neural tube. It started forming a tube, but this tube fused first in the center. And then with a zip, it closed up and another zip which closed down. Now, if the zip upwards has not closed properly, then there is a defect in the brain. If the defect has not closed properly below, there is a defect in the spine. So again, let me tell you, this is the brain. This starts getting folding. It folds and first touches in the center. And then there is a zip up and zip down. If there is a gap, then we call a defect in the neural tube, because this was a tube, this is neural tube, this was going to form. While this is taking circle, while this is taking a circle, you can see I am also enclosing a glass of water. This water was the amniotic fluid. This becomes the ventricle. And from this outer surface of the glass, which is the outer surface of the ventricle, the cells migrate and they reach the cortex. This paper is the cortex. So this is neuronal migration which takes place during the embryonic period. So if this tube is not formed properly, then it can have upwards is a defect of the brain. Now I had already told you that cephalus means head, but encephaly means brain. So anencephaly, A means absent, absence of encephalon, that is absence of the brain. So you can see the cranial vault is not there, that means the skull is not there, the skin is not there, and the brain is not there. If there was only absence of the skin, what would you call it? Anyone? If on the skull, I was seeing that there is only absence of the skin, then it would be known as cutis aplasia. If there was absence of the skull, it would be known as acrania. Crania means the skull bone. But if there is absence of the brain, then we automatically assume that the skin the skull, both are missing. So this is known as anencephaly. What is encephalocele? Again, let us divide it. Encephalo means brain, and cele, C-E-L-E, means herniation. So encephalocele is herniation of the brain along with its meninges through a defect in the skull. So you can find a mass. Now, both anencephaly and encephalocele usually are not compatible with life, especially not anencephaly. But if the lower zip is not closed, this is known as spina bifida. Bi means two, and fida. So there is a split into two. Spina means, of course, the spine. So this is a midline defect of the spine resulting in herniation or protrusion of the spinal cord along with its meninges. So what do we call this? Meningomyelocele. Cele means herniation. So meningomyelo. Myelo here is the spinal cord. So this has herniated through the spine because the coverings and the bone which should have kept it enclosed is missing. Arynencephaly. A means absent. Rhine means nose. Encephaly means brain. So it is a condition where a part of the nose is absent and a part of the brain may also be involved. A rhinencephaly. Encephaly is brain. Rhine is nose. So if you see the photograph below, there is no nose. And if you do an MRI, you will also find that there is holoprosencephaly. That means that it is not divided into two, but there is a fusion of the forebrain. So holo means whole, pros means forefront, and encephaly means brain. So the front portion of the brain has not been divided into two. So you can see one eye and there is a absence of nose. This is frontal encephalocele. Again, encephalon means brain, cele means herniation. From the frontal side, something has herniated, the brain has herniated. Nasofrontal encephalocele, occipital encephalocele, nasal encephalocele. Cele means herniation, encephalon means brain. Then for the eyelids, hemangioma. So you can see eyelid swelling. Ptosis, drooping eyelid. Coloboma of eyelid, cut in the eyelid. Anophthalmos, absence of the eye. A means absent and ophthalmos means eye. Microphthalmos means small eye. Congenital cataract, you see a white reflex. So you can now see the three circles. So if you see the innermost circle is white like a pearl, motiya bind ki tarah. Can you see this circle which is white in color? Then the circle which is out is looking like gray, but it could be either gray or blue. If it was an Indian child, it would have been brown. And then you can see the white. And you can see the eyebrow. You can see the white. You can see the brown. This is the iris. This is the sclera. And this. So now you see here. What do you see in this eye? If you see three circles, you can't make out three circles. The inner circle, which was white in this case and normally should have been black, is absent. So also the brown circle also cannot be made. When there is absence of both the circles with tearing of the eyes, this is known as Buphthalmus or congenital glaucoma. Here there is a small eye, so microphthalmus. Anotia, absence of ears. Microtia, there is a deformed ear. Cleft lip, cleft palate, cleft lip and palate. So, are you all with me or are you getting tired?
Yes, sir. We are with you, sir. And
Okay.
it's the time to take break also.
Okay, so let's take a break and come back after 10-15 minutes. Yeah?
Okay, sir.
Okay.
So we are keeping this meeting open, connected.
Yeah, connect.
Sir, hello. Good afternoon, sir. Please connect.
Yeah, tell me.
Sir, is it required to measure blood pressure of all the children? And how do we measure it?
Well, that is the biggest challenge in India. That is the biggest challenge in India because we don't get a proper blood pressure machine which is cheap for the newborns. I've been talking to that industry for a long time. So most of these cuffs are disposable cuffs. It is wise to measure the blood pressure. It gives you a lot of information. But in absence of it, you at least see the perfusion. You see the heart rate and the respiratory rate. So it is, but at least and you see the femoral pulses. So you may miss the blood pressure, but you must see the femoral.
Thank you, sir. Thank you, sir.
Has everyone come back? Hello?
Sir, just 2 minutes, 2 to 3 minutes, sir.
Okay, okay. ये नीरज हैं क्या नीचे?
Hello, sir. Hello, sir. RBSK resource material વાળી જે book છે એની અંદર પેજ નંબર 80 પર બર્થ ડિફેક્ટ અને જે પણ સરે આપણને આ એ દરેક કન્ડિશન્સ આપે Encephalocele, Hydrocephalus, Spina Bifida, દરેક condition with photograph. Page number 80, 79, 80. Green book check તમારી. Hello, hello, sir. Are you there? Yes, sir. All participants are here. Sir, you are not audible.
I'm now audible.
Yes, sir.
Okay. So now, so broadly, we have looked at the head, we have looked at the face, we have looked at the neck. Now, again, as a trainer, I will run through it fast, but then I will again come back. And when you are teaching doctors, pediatricians, then you have to go in some more details. So let us just complete it from head to toe fast, and then we can go. So then you see for the abdomen. Up, there's the first thing is scaphoid abdomen. What do you mean by scaphoid? It is the shape of a boat. So you can see this photograph. The child is getting oxygen. Any child which gets oxygen through the nose, through the mouth, will have a distended abdomen. But on the other hand, if you find a child with respiratory distress and a scaphoid, scaphoid means sunken and concave instead of flat abdomen, then you must know that the intestine must not be here. There must be somewhere else. And that is congenital diaphragmatic hernia. Usually it is on the, usually it happens on the left side, and then the heart is pushed to the right. So scaphoid abdomen, or you can get a distended abdomen, or there is a defect in the abdominal wall. The first is abdomen is scaphoid. The second is it is distended. The third is there is a defect. The skin muscle mass, there is a defect. This defect in the abdominal wall is known as gastroschisis. Then there is the abnormality of anus, which is absent, or it is present, or it is imperforate or abnormally located, or any abnormality in the umbilical vessel. All of you know that there are two umbilical arteries and one umbilical vein. And whether there is any hernia or hydrocele, both either in the umbilical region or in the inguinal region. So any swelling which is there, you have to pay. So the only thing which you have to teach is scaphoid abdomen. So here there is an atlas which has been given in the book. I am just showing you from the book. So this, if the abdomen is scaphoid and there is a respiratory distress, then for all practical purpose, you should think that this is a case of congenital diaphragmatic hernia and address for an urgent X-ray. This child requires urgent referral. So I told you that we have to decide on urgent referral, semi-urgent referral, and routine referral. This is an urgent referral. Then this, it is a high obstruction due to a small bowel, or a low obstruction due to a large bowel. But if there is an obstruction, there will be abdominal distension. If there is a high obstruction, then it will be associated with more vomiting. If it's a low obstruction, it will be associated with less vomiting. Now, as I told you, if the abdomen is open, that means what you find, the skin is not intact, the intestines has come out. Now, if it comes out, then your first thing is to see that what is the position of the intestinal loops coming out and the position of the umbilical cord. So can you see this umbilical cord? So what we find that the umbilical cord and the intestinal loops, there is no connection. It is coming out from the right of the umbilicus and there is no covering. While here, we can't separate the umbilical cord. And there is a covering. There is a sac. So when there is a sac, there is a covering, and I can't separate the umbilical cord, then this becomes omphalocele. Cele, I have always told, intestine. Cele is herniation. An omphallo is the intestine. So intestine has herniated out and there is a covering. But here in gastroschisis, schisis means cut. Someone has cut it. And so the intestinal loops which are coming independent of the umbilicus. It is not passing through this. Here, if the intestinal organs would have passed through this opening into this umbilical cord, then it would have become an omphalocele. This is separate from it. So, if there is a birth defect of the abdominal belly wall, the baby's intestine are coming out, it is not covered with a membrane. If the defect is to the right of the umbilicus and the umbilical cord is separate, and this requires gastroschisis, you should not allow in this way because the intestine will be losing a lot of water, lot of heat. On the other hand, the omphalocele, it will always be covered and you cannot separate the cord. Cord will be attached at the apex of the defect, and this is omphalocele. What do we see here? Imperforate anus or anal stenosis. There is no anal opening seen. So anal opening is too narrow or in the wrong place. So whenever you see in the anus opening, ask yourself two questions. Is the stool coming out from that? Is it the normal position or is it an abnormal position? If it is an ectopic position, it is known as ectopic anus. If stool is coming out from them, then it is an anal opening that may be narrow. Now, the intestines are not connected to the anus. An abnormal connection or there is a fistula. Then you see the genitalia. You press a torchlight. If it is brilliantly translucent, then you think that there is some fluid in it. So this is a hydrocele. What is the defect between inguinal hernia and a hydrocele? In inguinal hernia, the process vaginalis is open and intestine herniates into the scrotum. Whereas in case of hydrocele, it is only the water. Here also, the process vaginalis can be patent because unlike the adult, this is there. So it is also known as communicating hydrocele. Inguinal hernia and umbilical hernia. So we are seeing in inguinal hernia, the intestine has herniated through the inguinal canal into the scrotum, or it is obstructed in the inguinal area. There is an umbilical hernia. Usually umbilical hernia, nothing needs to be done. In case of inguinal hernia, you have to be careful that whether it gets obstructed or not. If it is a male child, one thing always learn that you must ask for the flow of the urine. Whether the flow is going at a distance or not. Never discharge a male child without documenting the flow. You can ask the mothers, most of them have a smartphone, that whenever the child is passing urine, kindly take a video. See whether the urine is passing drop by drop or there is a good flow. If there is a good flow, then it's okay. The next thing you should ask, where is the urethral opening? Is it at the right place or is it at the wrong place? Is it under the penis? Is it over the penis? If it is under, then it is hypo. Hypo means under. Hypospadias. If it is above, then it is epispadias. So then you see the penile size, which the stretch length should be 2 to 3 centimeter. C for the testes. Lot of time you will not get the testes, but that is because there is a retractile testes. So always rule out the retractile testes. In a female child, the genitalia of a female child is very difficult to understand, even among doctors. So please find it, be very gentle. Sometimes you can get blood from the genitalia. This is normal. Just like the menstrual blood, some of the newborns, because of the maternal hormone, can have blood. That is normal. But you should understand where is the clitoris, where is the labia majora, where is the labia minora. These two are very, and then the opening, the urethral opening and the vaginal. This you need to understand, and small amount of vaginal bleeding is secondary to withdrawal of maternal hormone. If you have identified the vaginal opening which is lower down, then whether there is any tag or any discharge is also normal. And then so in cases of preterm, the labia majora doesn't cover the minora, so you will find them separate. The clitoris sometimes may have a relatively prominent appearance. If you have any doubt, then you can call it ambiguous genitalia. Ambiguous means you are not very clear. So ambiguous genitalia in majority of the cases, like in this case, you can see that this is a true female. Usually they are females. And suddenly they may go into shock because they may be salt losing. Their 17-hydroxyprogesterone is low. So they have very low sodium and very high potassium, and they can go in shock and they can die. So if you find a child in shock, instead of thinking of a sepsis, you should also see the ambiguous genitalia. In a male child, it becomes very difficult, but in a female child, it is easier. So hyperspadiasis, opening is under the penis. So you should ask where from the urine is coming. So it could be glandular, subcoronal, distal penile, midshaft, proximal penile, penoscrotal, scrotal, and perineal. Vaginal agenesis, there is an absence of vaginal opening. Epispadias, EP means above. So it is above the penis. And if it is very large, then there can be bladder extrophy also. So this is bladder extrophy, where the urine bladder is malformed and exposed inside out, protruding through the abdomen. Then you have prune belly. So if you see the abdominal skin like a pruned, so that means like an old man's skin, all wrinkles. Then this could be prune belly. Usually you have undescended testes in males and urinary tract malformations. So the abdominal appears large, loose, lax, wrinkled, shriveled. Sometimes the flow of the urine is not good and the bladder is distended. This commonest finding is posterior urethral valve. Here the obstruction is beyond the bladder. There is a tissue which is blocking the urethra in the posterior urethral. So this is, you get a distended bladder even after the passage of urine. Some syndromes are also there. You can have oligohydramnios, and you can have a child whose face appears to be very flat, as if someone has pushed, and the limbs are in abnormal positions or contractures. It's wrinkled, there's decreased amniotic fluid, the lungs are not well developed. So this is Potter's syndrome. When you see the limbs, then always remember the proximal, the middle, and the distal. So this proximal, if I see our upper hand, this is the upper arm. This is the forearm. There is only one bone here, but there are two bones here, the radius and the ulna. Then there is wrist and there is carpal bones. So then of course the phalanges. Now what can it happen? There can be complete absence of the upper limb. The whole limb is not there. Or it can be that the arm and the forearm is absent and the wrist is directly attached to the shoulder. This kind of children were seen when there was thalidomide. Mothers were taking a medicine for vomiting, and because of that medicine, there was a defect which was also known as phocomelia. So, if there is a defect of only one bone, so arm is formed by one bone, but forearm is formed by two bones. So supposing there is a reduction defect of radius, then this will be curved. So you'll have a curved bone. Then you can have the defect in the fingers. So it can be like a scissor, lobster, claw hand, or they can be, same thing can be applied for complete absence of the lower limb, or the foot is directly getting attached to the thigh, or both the lower limbs or the foot and toes are absent, or there is a split foot, or there is a congenital shortening of the lower limb. Just like the upper limb, the lower limb, that means the femur, and below that is the two bones, which are the tibia and the fibula. They are, one of them may be absent. Then they can be extra finger. Usually these are not associated with much problems, or they can be syndactyly. They can be fused fingers, or they can be clubfoot. Now clubfoot is something all of you should know how to teach. So those who have attended my session in 2013 or later on would be knowing, but the commonest message which I give is that stretch your hands in this way, and you will think that this is the foot and this is the leg and this is the thigh. Now, usually the foots are in this way. So what is talipes equinovarus? First you raise your heel. So can all of you do in this way? Then this will allow you to practice. Think, just raise your heel. This is the heel. So it gets raised like a horse, equinus. Then the second is turn the sole which was facing the foot which was facing the soil, it will now face the sky. So let us turn in this way. So first is heel raised, then let us turn it. The foot facing the sky. So if it is foot facing the sky. And then the forefoot is brought close to the hind foot. So there are three movements again. Number one, the heel is lifted off. This is the first movement. The second movement is the sole facing the sky. This is the sky. So sole facing the sky. And the forefoot adducted on the midfoot. So these three movements makes it talipes equinovarus. So the foot, especially the heel, is usually smaller than normal. And remember, the foot is, now can you see here, the two soles are facing the sky. They are turned in this way. There's a rotation. And then the forefoot is actually, so there's a crease here. The forefoot has adducted on the midfoot. So all these three makes it. And what is the treatment? The treatment is, don't try to correct this by force. Never try to touch the heel. First thing foremost is just to support. Don't try to correct the rotation. Don't try to do it this way. Just support it. Lift the fingers. So there's a serial plasters which are done. And then bracing is done. And after serial plasters, there was a Spanish doctor who was in America. Anyone will know the name? He has now died. Who invented this idea of serial plasters. And sometimes he cuts the tendo Achilles because there is a contracture here. Can you name the doctor? Anyone? I've given you the hint, he's a Spanish. Yes. Yeah, very good. Someone said Ponseti. But you should know another Ponseti's disciple who worked with him, and he was from Gujarat. He was Gujarati, but though he was not born in Gujarat. Anyone know his name? He has come to India to give lecture. He has gone to Gujarat also to give lecture. Very famous personality, giving the score. Shefi Pirani. Shefi Pirani is actually from Gujarat. So you have at least one person from Gujarat who is associated with this clubfoot. Now, then you come to Down syndrome. Now in Down syndrome, what are the things you see? So as soon as the child is born, you'll find that the the two, instead of flexion, they are falling flat on the table. And the limbs are very loose. So there is a hypotonic baby. When you look at the face, you find that the bridge is depressed, nasal bridge is depressed. And there is a medial canthus. यहाँ से काजल लगाना आप लोग शुरू करते हो, where the two, you see, the canthus meets. There's a medial point. Now this medial point, all of you can see your own medial point, where the upper and the lower it meets. This is covered by a skin. Since the skin usually comes from above, we call it EP, means above. Canthus is the inner canthus, so we call it epicanthic foot. Now usually this medial canthus and the lateral canthus, if we join them, they come like a straight line. But if the outer canthus is moving upwards, then this is known as upward slanting eyes. आपने कभी देवी या प्रतिमा की फोटो बनाई होगी, तो ऐसे जो आंख बनाते हैं, that is the down syndrome, upward slanting. The inner corner of the eyes are rounded, they are small and deformed ears, small mouth, sometimes the tongue is coming out, there's a flattened nose, there's a single deep crease along the center of the palm. And the fifth finger has one bending. So you find known as clinodactyly. The has one bending joint instead of two. So instead of these two things which you are seeing, दो पोर जिसको कहते हैं, एक ही होता है. Now if you see the foot, earlier days, instead of shoes and slippers, हम खड़ाऊ पहनते थे. तो खड़ाऊ में क्या होता था कि थंब और फर्स्ट फिंगर के बीच में पाँव में वो उसको पकड़ के चलना होता था. तो the gap would increase between the first finger and this. The similar thing happens, इसलिए इसको saddle shaped deformity भी कहते हैं, sandal gap भी कहते हैं. A big space between the first and the second toe. So if you get all this, not one feature, some of you may have a single crease, but you are not Downs. You don't have any problem. But if there's a constellation of other things, then you can think of a syndrome. And one of the commonest syndrome is Downs. Two things remember. We all know Down syndrome happens in older age group. But in India, maximum Down syndrome happened to younger mothers. You will tell why. It is a statistical game. In India, majority of the pregnancies are over by the age of 30 to 35. Maximum. So naturally, though we know that Down syndrome will occur, above 35 there are very few pregnancies. So if there's a few pregnancies, there will be very few Downs. So majority of our Down syndrome in India is for younger mothers. So next time don't get surprised if you see a Down syndrome and you see a younger mother. So upward slanting eyes and the inner corner may be rounded, small ears, flat nose, small mouth. So how do you teach them? You ask them to make a photograph. Make a photograph of a normal child, make a photograph of a Down syndrome, then they know how to differentiate. That's the way to teach. So the single crease, you can then show wider short hands with short fingers, sandal-shaped deformity. And you can see a tone of a normal child and tone of a Down syndrome. It is known as frog-like. So after that, you can ask the participation to add notes regarding the new knowledge that emerged from this module. So what you require, if you have one thing, just have a torch. If you have two things, then have a torch and a bell. Or you can have such things where black and white stripes, a red or a color or yellow color, and an ophthalmoscope. So you have to see whether there is a distorted appearance, there is a drooping eyelid. All that we have said. We have said also of the red eye, rounded pupil, red reflex. So we just run through it once again. Partial closure of the eye, hemangioma, eyelids are too narrow, gap in the eyelid, facial marks, capillary hemangioma. So we have gone through small eye, no eye, coloboma of the iris, conjunctivitis. I was talking about dermoid. This is in golden hammer syndrome. So you can see this yellow piece coming onto the sclera, outer circle, and sometimes even entering the second circle. This is this. And then you can see the simple, the white pupil like a pearl. Actually, some of you may say this is cataract, but very similar to cataract if it is yellow in color. This could also be a cancer, retinoblastoma. Now you can see this is in cataract you are seeing, but in corneal clouding and in glaucoma, both the two circles become white. In fact, there is only bluish once. And if there is tearing of eyes, there is glaucoma. If no, then it is corneal opacity. So you can fill this form. Now, in RBSK, we have allowed you to have an optometrist. An optometrist which can also take care of the vision. So today is not the day to teach you cortical visual impairment, but for ROP, when I was the head of department in Calcutta, next to my newborn care unit, I had developed this. So both these two girls are optometrists. They're not eye doctors. And I have given them a camera. Those days the camera was very costly. Nowadays you have a cheaper camera which has been allowed in RBSK for you to buy. So with this camera, they could take the fundus of all the children. So they could pick up even chorioretinitis, which would lead to, what is chorioretinitis? That is, you get certain spots on the retina because you can see the fundus through this camera. And one they would then send it to a doctor. This is our ophthalmologist, Dr. Pranab. So he'll get all the images, then he decides. And this laser used to be kept in the nursery, NICU. He would come, need not bring the laser, he would come and give the laser. Because of this, some few thousand lasers have been given in the last 7 years. Not only for newborn born there, which is a 100-bedded unit, but also from other places. So you can see by keeping an optometrist, a camera, and a laser set, you can engage any doctor to come and do your ROP. And this is the form which they can fill. When you are examining the ear, please ask them, the best way is not to remember helix, antihelical fold, tragus, lobule. All you tell them, look at your friend's ear. look at your friend's eye and make a drawing. If I had asked you to look at your friend's ear and make a drawing, you would know exactly how the folds are. You may not remember the names, but if you know the folds, that's okay, good enough. So I had made you run the train from Bombay to Vadodara. So the train journey started from here. The sound wave started from here. And Vadodara is the brain. So the sound waves must have traveled from here right up to the eardrum, and then from eardrum across the middle ear, on up to the cochlea, and from the cochlea, the electrical signals went up to the brainstem, and from the brainstem went to the temporal lobe of the brain. So this is the entire area. So you can have microtia, you can have ear tag, you can have preauricular pit, you can have a hypoplastic and a low set ear. So what is low set ear? As I told, the outer and the inner canthus are in one line, and if you make it run more straight, it should cut the ear between upper 1/3 and lower 2/3. But remember, the ear is straight. If the ear is rotated, then you can't say low set ears, because for low set ears, they have to be straight and low. If they are rotated, then you can't talk of low set ears, because then the line will pass above the ear, but that is because of the rotation. So again, there is a form. We are asking all the SNCUs and NICUs under RBSK to buy a telephone bearer. It's a screening bearer, only one of its kind in the world. It is so easy. You can, for low risk children, those who are not, you can use a OA screening. Then if you don't have all these costly machines, you can buy this Arfi machine costing you only 5,000. It can produce different sound waves. So sound has two properties essentially. One is the amplitude and one is the frequency. कभी आप समुद्र के किनारे जाएंगे तो आपको वेव्स में दो चीजें देखनी होती, वेव्स की ऊंचाई और कितनी वेव्स आ रहे हैं, एक मिनट में कितने वेव्स आ रहे हैं. जो वेव्स आ रहे हैं वो फ्रीक्वेंसी होगा और उसकी ऊंचाई जो है वो एम्पलीट्यूड. सो यू कैन टेस्ट देम. You can test for various frequencies. In fact, this is next to my NICU, under neonatology, under pediatrics, this is not ENT. So you can see this whole was getting done. Again, there is a form. Again, this is for screening for, so these are all functional defect screening. So if the difference is greater than 95%, and if the right hand and left foot difference is less than 3%, you have passed. But if it is 90 to 94% or there's greater than 3, then you repeat. And if it is still less than 95, or if it is less than 90 at the first go, that's pathological. This is the form. This is what you have been shown. The definition of dysmorphology. Now also, you have to see what is dysmorphic. It was first coined by David Smith. It implies study of humans. So anything which doesn't appear like normal, you can always put it as dysmorphic, because physical features are not usually found with others. So dys means disordered and morph means shape. Dysmorphism. So this is a shawl scrotum configuration. This is partial skin dactyly, clinodactyly. Can you see? There's only one joint. Usually there are two. So what is association? Now sometimes you don't get a particular syndrome, but you get some things which occur more frequently than expected by chance alone, but do not have a predictable pattern or unified etiology. So vectoral abnormalities, vertebral, anal, cardiac, tracheoesophageal, renal, limb. This is not a particular syndrome. We do not know if there's a particular gene defect. But we know that these associations are normally seen. So if you get one abnormality, you should see for others. So this is known as association. Use of term association does not indicate a specific diagnosis has been made. But the association is not by chance alone. So here you can see absence of radius and there is an anal atresia as a part of Vater. So V stands for vertebral, A stands for anal, C stands for cardiac, TE stands for tracheocecal fistula, R stands for radial and renal, L for limb. Vater or vactral. It's better to remember the word vactral. V for vertebral, A for anal, C for cardiac, TE for tracheoesophageal fistula, R for radial, renal, and L for limb. Sometimes it is known as sequence. So what have we said? We said first of all, there is a syndrome. In syndrome, we have a particular gene or a particular chromosome which is defective. Association, we do not know. But we find certain problems getting associated. Then we see sequence. Sequence means if there is one defect, then the second part of the defect will be sequentially related to it. So if you get hypoplastic mandible, so this mandible is behind, then what is the sequence? The tongue has to be behind. If the tongue is behind, then they will be choking. It will be. Now when you get such a sequence, then this is known as sequences. One such sequence very commonly seen is Peary-Robin sequence. So the mandible is behind, there is a posterior displacement of the tongue, there is a cleft soft palate, and there is the oligohydramnios. Or they can be Potter's sequence, that is lung are less developed, flattened faces, and abnormal positioning of the lips. So this is malformation, a pattern of multiple defects resulting from a single primary malformation. So talipus and hydrocephalus, if you find both, this could be a malformation sequence. It is sequence because of neural tube defect. So there was a lumbar meningomyelocele, due to which there was also talipus and hydrocephalus. So these are not independent, these are sequentially related. Typical Peary-Robin syndrome. Then you have this format which you can fill. And if you see this format, there is one portion which talks about the place from where you are reporting. Now you may say, sir or madam, this form, let us keep it at the site of the places where the delivery is occurring. What if this delivery is missed? And this is picked up by the ASHA worker or by some tertiary hospital. How to know, how to report? So in RBSK, it has been simplified. Supposing I get a 2-year-old child, I'm sitting in Gandhinagar, who has a congenital heart disease. So I ask him, am I the first person to identify? He says yes. Then I tell him, okay, which district does he belong to? Where was he born? No, he was born in Vadodara. Which year? This year. So I enter it that this child actually was born in this year in Vadodara. So what happens? That this data will shift. This data will shift 2 years before dynamically, and the number of children born there, live births, this will go there. So maybe there was 10 defects. Just a minute. Hello. Hey, Papa, I'm in class. So this data will shift. That means even if you miss during the newborn, there is no duplication. This data will shift there in Vadodara. So from Vadodara, CMH has reported that in the year 2016, 10,000 children were born, only 2 birth defects. Now this case will get shipped 3 birth defects. This will not be added here. So it is very simple. So what we say, where is the location of the reporting? So the location of the reporting and location of birth may not be the same. Are you an ASHA, sub-center, even a private nursing home, a tertiary center? So reporting month and reporting year. But I will ask him only 2 things. At what age have I identified? Have I identified at 1 year? Have I identified less than 1 month? Have I identified at birth? Have I identified at beyond 6 years? Date of birth and what was the outcome? Where was the child born? So even if you don't remember the date, you just put the year. And was it a single, twin or a multiple? What was the sex? Was there any birth asphyxia? Sorry. So if the status of induction and augmentation, now this is all about the mother and the child. Then some antenatal data. Nowadays, a lot of assisted conceptions are being done. My own understanding is, and this is not my understanding, there's a Cochrane review which shows that nobody tells, because IVF has become a business, that because of IVF and ART, there are more birth defects than normally seen. Why? Because in nature, you allow the sperm, the egg to choose the sperm among 1 million sperms. So the permutation which the egg gets is 1 million sperm to choose, and it is choosing only once per month. The egg does not wait for anyone. If within 24 hours the sperm is not already waiting, gone, come next month. All the number of eggs are already formed when this mother was in her mother's womb. That means if you are giving some drug to a pregnant lady who is carrying a female child, you are impacting 2 generations. Because that girl child which is in the mother's embryo, all her eggs are already formed. Not a single new egg will get formed after her birth. This is not true in sperms. So, it is very important for a civilized society to understand that if a mother is carrying a female child and you mess up for more than 1 generation. And I called a line. When a mother is pregnant with her girl child, she is also pregnant with her great-grandchild. So, the next thing what you do is you write the type of defect. If you cannot write the name, just write the ICD-10 coding. It is confirmed or suspected. Then this is visible birth defect. Then you should write, have you done hearing test? Have you done vision test? Have you done congenital heart disease? Then it is birth defect. If you have sent blood examination for IEM, then you can tick CH, G6PD, others, hemoglobinopathies. And finally, if there is some neurological defect, you can write. And then the karyotyping. So it is very easy, wherever you are referring, that if you can't make anything, just make a round shadow. If it is on the eye, just make a round shadow on the eye. And then there are certain things which are written. The doctor can just mark it. It is very simple. On a pictorial, you can make it. You will not miss the birth defect. So this is the screening form for hearing. Now remember, all over the world, hearing screening form only consists of OA. For the first time in RBSK, we said, no, please take a history. If there is a history of hyperbilirubinemia, if there is a history of body weight less than 1500 grams, if there is a history of aminoglycoside and Lasix, if you have ventilated the child, if there is some craniofacial abnormality, if there is a delayed cried or birth asphyxia, if the child has developed sepsis, or there is a family history of hearing loss as a young child, or there is some congenital in utero infection, then you are already screen positive. Then you need to do directly the BERA. And then see the visual inspection. How does the ear look like? Is there some spot? What is the ear shape? If the risk factor, what it means that if there is a risk factor and your OA screen is not negative, it has passed, still you will ask the person to come because there is a very high risk factor. So this is screening come referral code for eye. This is the poster again. This all you have seen. Now this is for the neurological development. What is normal? What is abnormal? So this I will explain you when I'm teaching you. So this is the kind of a, so you have a screening committee, you have a state, all this comes. And in Kerala, they are also doing, apart from visible and functional, also metabolic screening. So they have made a government public health lab where all the samples can be collected, sent there, and they can do the screening and then can give a report online. The way you are getting your online reports during COVID times. This is very, very simple. It has been done in a lot of countries like Philippines. Kerala is doing it, and you have the data. So before setting up a newborn screening, please take care that you have a screening committee. You have to set up a regional public health lab if you want to do metabolic, quality assurance, how will you transport, reporting format, how will you maintain your data, and key. So I stop here only to tell you that in case of blood, don't rush for very costly equipments for doing tandem mass spectrometry and GCMs. I will ask all of you that please do the routine blood test properly, even if you are suspecting in IEM. So there are two kinds of screening in metabolic. One, where you do universal screening. That means you don't wait for symptoms to come in. One, in which you do screening for a symptomatic child. When you are doing screening for a symptomatic child, very simple things like doing a blood gas, finding the anion gap, finding the fasting blood sugar, doing an ammonia, doing a lactate, doing a liver function test, doing a creatinine, testing for reducing substance, testing for ketones, developing the skill to do simple ferric chloride and DNPH and cyanide nitroprusside test, or even MPS spot test. If you don't get it, then there are few labs in this country which are in government sector, both the NIMANS and where you can send it. Now this is the complete picture of birth defects and you can do. So the screening, evaluation, management, this is what the people will do and this is what has to be done with the DIC. So is it okay? And this was the line which I was referring from Gitanjali. The smile that flirts on the baby's eyes, does anyone know from where it comes? The smile that flickers on baby's lips when he sleeps, does anyone know from where it was born? Yes.
Thank you so much, sir, for great details about birth defects. Any questions from participants? Anything that is not understood? Yes, sir, there is one question.
Yes, please.
Sir, hello.
Yes, please.
सर मैं डॉक्टर AS ठाकुर हूँ सीनियर
हाँ जी।
मेडिकल ऑफिसर,
हाँ जी,
जिला
हाँ जी,
तालीम बोल रहा हूँ।
हाँ जी।
सर आपने बहुत अच्छा वैसे बताया। ग्लोकोमा का जो एक्सटर्नल फीचर्स है सर, मुझे फिर से समझना, वो जो सर्कल के बारे में आप बता रहे थे ना सर,
हाँ बिल्कुल बिल्कुल
एक बार फिर बताएंगे सर ग्लोकोमा के बारे में?
बिल्कुल बिल्कुल बिल्कुल। मैं अभी आपको वो फोटोग्राफी ले आता हूँ, एक सेकंड। तो अगर आप ये फोटोग्राफ देखें तो इस फोटोग्राफ और इस फोटोग्राफ में आप क्या देख रहे हैं, इसमें एक अंदर इनर सर्कल है जो कि काला था, उसके ऊपर एक सर्कल है जो कि भूरा है, एंड दिस इज द व्हाइट सर्कल. So again I am repeating, let me show some other photograph. Okay, let me see if I can. If you see this circle, the innermost circle should have been black, then you have the second circle, then the third circle is white. See here, this inner circle and this circle, they have fused, and you have only blue, nothing else.
Okay, sir.
So when you are seeing that both the circles have fused, you cannot discriminate the two circles, and at the same time there is watering from the eyes, then it is congenital glaucoma. If the two circles, you can see only one circle, you cannot make out separately, but there is no watering, this is corneal opacity. If you see this eye, the inner circle, you see the brown, the blue one, the iris, there is a cut here like a keyhole. This is coloboma of the iris. Here you see a dermoid going onto the white circle and going onto the second circle. This is what is golden. So I think, let me show you something better.
Right.
Yeah. See here.
Right.
Have you been able to appreciate the 2-3 circles? Yeah.
Yes.
Okay. Okay, if there is no more questions.
Any other question?
But I will request you to kindly open the book, download the book and read it.
Yes, sir. That will we will also provide soft copy
Okay, okay.
in pen drive.
Yeah.
Any more questions? Sir, there are no more questions coming.
Okay.
Thank you very much for a wonderful session. I would request Dr. Rastriya Upadhyay, sir, to close.
Thank you very much, sir, for your very lucid explanation of complex problems, sir. Hello.
Yes, yes, I can hear you. I can hear you.
Right. Thank you so much, sir. And we'll be waiting your arrival tomorrow in the morning, sir.
Okay, sure, sure, sure.
And tomorrow we'll basically discuss about the developmental, normal development and developmental delays, sir.
Okay, okay.
That will be including DEIC and first 1,000 days.
Okay, okay.
Thank you so much, sir, from our side, sir. Thank you so much, sir.
Thank you, thank you, thank you.
તાળીઓનો અવાજ નથી આવતો.
Thank you.
Thank you, sir.
Thank
so maybe end this meeting now, sir? And
Yes, yes.
we are concluding the day.
Yeah, yeah.
Thank you.
Thank you.
So Dr. Arun Singh, sir, will be
Yes, sir.
traveling.
Yeah, tell me, please.
Sir,